Welcome back to Musculoskeletal History and Examinations Part 2. We're going to look at another 2 or 3 cases and follow through the history and examination. So let's move on to case 4. We've got a 50-year-old man with shoulder pain after painting a ceiling 2 weeks ago. What questions would you ask him? So again, with any symptom, you may want to know how long it's been going on for. It's about a week now after painting the ceiling. Where is it exactly? He's talking about the outside of his shoulder, the deltoid area. Is it affecting his sleep? Yes, it is when he sleeps on that shoulder. And what exactly is it affecting? What kind of things in terms of his daily living activities? He's finding it difficult to comb his hair, lift things out of cupboards whenever he lifts his arms above his head. Is there any stiffness? No. Is there any weakness? Yeah, he's finding it difficult to comb his hair, and holding on to the comb, you can't do that. Any past history? Well, yeah, he's a painter. That's his job. He's had repeated episodes of shoulder pain like this, but not to this extent, and not where he's noticed some weakness. Does he have any medical problems? No. Is he a smoker? Yes, a packet a day. So this looks typical history of rotator cuff disease. Typical triggers in people with rotator cuff problems, people do repeated activities, maybe sportsmen, maybe certain jobs like painting, anything above overhead activities, builders, for example. Pain typically is over the deltoid area. It's hard to sleep on that affected shoulder. Depending which tendon or rotator cuff muscle is affected, that can affect different activities. Take, for example, the subscapularis tendon. If that's inflamed, putting your hand behind your back is difficult. So tucking a shirt into the back of your trousers, putting a belt on, or doing a bra up if you're a woman at the back is all difficult. Supraspinatus tendonitis, again, pain reaching up for things, so overhead activities, things like combing your hair. Infraspinatus tendon, this is involved in external rotation of the arm, which is less important for activities of daily living. Often you get around this, moving your arm in a different direction or using different rotator cuff muscles or even the deltoid, so often we can compensate. There's not one specific activity of daily living that really relates to the infraspinatus as easily. Weakness is a key thing you want to know. Unable to lift their arm up or off their back in the Gerber's lift-off test. And again, if you've got muscle wasting, then this has been a tear, a full thickness tear, not a partial tear, for a significant period of time. And so under use of the muscle, it begins to waste. We're testing the different rotator cuff components. Remember the different motions of each rotator cuff component. So supraspinatus is involved in abduction. You want to put the person in the empty can position where they are pouring out a can, and you ask them to abduct their hands away as you put resistance against them from about 45 degrees outwards. External rotation, looking at the infraspinatus, you want to ask them to lock their elbows into the side of their body and then move their hand outwards from that position, and you resist that. Checking for weakness, pain, and strength and range of movement. How far can they move? Again, internal rotation, subscapularis motion. You can ask them to put the hand behind the back, and how high can they get the hand up the back, to what level? Should be able to get to T7 on both sides. You can compare both sides to see if there's a difference. Again, you ask them to lift the hand off the back, and then against resistance, looking at the range of movement. Is there any weakness? Could there be a tear? The problem is when looking at the rotator cuff or the shoulder in general, there are lots of tests. In fact, probably over 150. And so when you see that there's lots of tests in a joint or a situation, that often tells you that there's not one good test, and that one test in itself cannot give you all the information you need, or unfortunately isn't sensitive or specific enough. So most papers, when you look at the evidence, conclude that one test in itself is unable to rule in or rule out any specific shoulder condition. So you need to have the full clinical picture. You need the history and examination together to make an estimated guess as to what's happening. So for example, clinically you can say that a patient has subacromial impingement, maybe they've got a painful arc, maybe they've got a positive Hawkins-Kennedy test, but there are many causes for that. For example, it could be the supraspinatus tendon is calcified. Maybe there's a rotated cuff tear and the frayed tendon's causing pain as it goes through that window between the acromion, subacromial bursa, and the joint space. Or maybe it's the bursa that's inflamed. Maybe it's the curvature of the acromion itself. It makes it more likely that they're going to get subacromial impingement. So there's many possible causes of pain in that area. Here is the window, which gets narrowed between 60 and 120 degrees, and that's where you get the painful arc. You see the supraspinatus tendon comes through that window. Also the bursa sits there. The ligament also can be inflamed. You could have arthritis of the shoulder possibly as well. And the acromion itself, could be of a certain anatomical structure, impinges on the tendon as it goes through at that moment. So this is just to make the point that you need both the history and the examination, and what things are more likely with one thing than the other. So if you're looking at rotated cuff disease, you get pain, you can get impingement, you can also get weakness if there's a tendon tear. Subacromial bursitis, again you get pain, impingement, you won't get weakness because it's not a tendon problem. Adhesive capsulitis or frozen shoulder, talked about this already, you get pain in the first 2 to 9 months, loss of mobility, not being able to move the shoulder in all directions, but particularly external rotation, occurs at 4 to 12 months. And then you get this condition resolving over a year to 2-3 years. Again, osteoarthritis of the joint, you get pain and movement and stiffness. A particular test you may find helpful here is the scarf test, where you ask the patient to wrap their arm around the neck and you push up against the elbow to see if there's any pain. Let's move on to another case. A 65-year-old man with painful joints and stiffness. So what are you thinking now? Stiffness. Earlier we talked about muscular problems, but also arthritic problems with stiffness. So what would you want to know? I would like to know more about the stiffness. When does it come on? Is it the beginning of the day, at the end of the day? How long does it last for? So here in this history, it's 30 minutes in the morning and then eventually goes after about an hour. Which joints of the hands are affected? The patient's saying the MCP joints when you ask them to point, the knuckles. Have you noticed any warmth or swelling in your joints? Yes. Do you have any rashes? No. Any eye pain or problems with your vision? No. Any weight loss? Yeah, some mild weight loss. Have you noticed any fever? Yeah, I've noticed slight fever too. And when you're going to examine the patient, here are some findings you'll find with somebody with rheumatoid arthritis. Notice the ulnar deviation away from the radius, in other words, the ulnar direction, hence it's called ulnar deviation. Also notice the swan neck, the bird, the swan, and how the two different joints are deformed, causing the swan neck deformity. Here it's just one joint that's deformed, the boutonniere's deformity. And these are typical findings of somebody with rheumatoid arthritis. You may also notice some muscle wasting here between the metacarpals. And again, the joints of the MCP joints be warm when you feel them and swollen. This is just to show you the difference between rheumatoid and osteoarthritis. So osteoarthritis is a degenerative disease. It's a wear and tear disease. Morning stiffness can happen, but it lasts less than 30 minutes. Whereas in rheumatoid arthritis, it's an autoimmune disease. So it's an inflammatory problem in the joint. You do get morning stiffness, but it lasts more than 30 minutes. It usually goes within about an hour. Looking at the hands, you will find Hebden's nodes in osteoarthritis. Often it's asymmetrical, it's different joints on either side of the body. Whereas in rheumatoid arthritis, you can get rheumatoid nodules, you can get the MCP joints in both hands are affected, so it's symmetrical. And it starts off in the hands and feet. Osteoarthritis maybe could start in the knee, the hip, start in different joints. This is just to re-emphasize, osteoarthritis, the MCP joints are not affected. In rheumatoid arthritis, the DIP joints are not affected. So you really want to know which joints are affected. Look at the MCPs and the DIPs, and that'll give you a clue as to which type of arthritis it could be. So in this case, this man, he's got morning stiffness lasting 30 minutes, particularly eases off after that time. Usually starts in hands and feet first, after the MCP joints, spares the DIP joints, but can occur in any joint, and is often symmetrical, the same joints on both sides of the body. The joints can be warm, swollen. It is an autoimmune disease. Fatigue, so you can get this chronic anemia, normocytic anemia. Low-grade fever with weight loss. And 40% of patients experience non-joint problems. So you do need to screen for particular problems with autoimmune disease, connective tissue disease. We will maybe just ask some questions about any rashes, any eye symptoms, any pain, any visual loss, any problem with the lungs, breathlessness, again, any problems with GI symptoms, any problems with swallowing or GI upset. Again, in rheumatoid arthritis, you may want to listen to the heart, check the kidney function, look for any vasculitis, inflammation of the blood vessels, and also check a blood test for the bone marrow. Let's move on to our last case, case scenario 6, a 76-year-old man with pelvic pain. So, again, when did it start? 6 months ago. Then sudden severe pain started 4 days ago, and that's why they've come to see you. What type of pain is it? Well, it's quite a gnawing, kind of achy pain, and then it suddenly became severe and sharp, really severe, maybe 10 out of 10 on the pain scale. Is it continuous or does it come and go? Well, it's been continuous. It's keeping me awake at night. I can't sleep with it. Any pain anywhere else? No. Any joint pain problems elsewhere? No. Any weight loss? Yes, about 7 kilograms. Any fatigue? Yes, I feel quite tired. Any difficulty passing urine? No. Go more often to pass urine? Yes, I am. So there's something going on with the urine as well. And I just wanted to highlight that bony problems, musculoskeletal problems, can also be underlying cancer. So you obviously can get primary bone cancer or secondary problems like metastatic disease from primary cancers. Here I wanted to just highlight the problem of multiple myeloma, a disease in the elderly particularly. Often they complain about bony pain, often in the ribs or the back, in the lumbar spine. This can lead to fractures, and this is what's happened in this case. This man's had sudden, sharp, severe pain because he's got a lumbar wedge fracture. Now, In multiple myeloma, obviously it's part of the bone marrow that's been affected, and you can go into bone marrow failure. Remember, the bone marrow produces red cells, white cells, and platelets. So all these different types of lines of the cells can go wrong. So you can get anemia, you can feel tired, feeling weak. You can get low white cells, you get recurrent infections and fevers. You get low platelets, so you get unexplained bruising or bleeding without any obvious trauma. Obviously, weight loss is a symptom. Because of hypercalcemia in multiple myeloma, you can get constipation as well, and increased thirst and urination, and that's what's going on in terms of passing more urine. It's more thirsty. You obviously just want to make sure it's not in kidney failure. Other possibilities in this case would be if the problems go more frequent to the toilet, and problems with stopping and starting. Could this be a prostate problem? Could be a prostate cancer, for example, with a metastatic disease in his spine that's caused a fracture. So I'd be thinking about those two different possibilities, definitely with multiple myeloma probably, or prostate cancer with a metastatic spread into his spine. I mean, there are other causes as well. You could have osteoporosis and a fracture that's happened. Maybe there's a disc involvement with its back pain. So just have a broad range of differentials. When thinking about taking history and musculoskeletal history, do ask about possible red flag symptoms of cancer, such as weight loss, problems with the bone marrow, like asking about tiredness, infections, bruising. Also think about sweating, particularly nocturnal sweats, and then think about possible primaries that could be contributing to metastatic disease. So I would ask questions about passing urine, somebody with lower back pain problems. Yeah, so just think widely. I hope you found this helpful. Again, resources, look on Clouds in the musculoskeletal history and examination chapter. It's very helpful. If you want to look up some more things about some of these diseases we've talked about in this presentation, like rotator cuff disease, gout, rheumatoid arthritis, even anterior knee pain, patient.co.uk has a very good summary of all the evidence written in a way for patients to easily understand, but great for doctors too. Shoulder Doc is a great resource in terms of images, examinations. Arthritis.org gives you more information about arthritis. The Mayo Clinic, I think, is great at looking at symptoms and signs that fit together. So yeah, hope you found this very helpful. Do comment if you would like to feedback to me.